We get Francine is calling. Hi, Francine.
Hi, Dr. Waching. Good morning.
Good morning, Dr. Vajan.
How are you? How are
Very
you?
good. Very good.
Good.
Thank you. Yeah. So what time is it now in India?
Oh, it's going to be 5:20 p.m.
Oh, okay. Not bad.
So we just finished Asia Pacific Academy of Ophthalmology long council meeting,
Oh, yeah.
and we're going to have shortly a general assembly too. Hi, Hudson. Good morning.
Good morning, Natarajan. How are you doing? Everything's fine?
Wonderful.
Our
Wonderful.
vitretinamaster course is a good success. You know, people are liking a lot. I'm sharing with
Yeah.
people from the residency and fellowship programs here, but some of them are not used to the broadcasting things. But next time we're going to have more participants.
Sure.
Would be great. So what
hello.
time is it now in India? It's close to 5:30.
5:20 p.m. Hi, Marcelo.
Hi, Dr. Natarajan.
Good morning.
Good morning.
Good morning.
Good night for you.
Yes. Hi, Lord. Hi, Larry. Larry has joined. Lawrence.
Yeah, Lawrence is around.
Yeah, but the screen is on. I'm seeing.
So, Rafael, everything all set?
Hudson.
So do you have the order, Hudson? The order of speaker?
What is that?
No. Who's going to go first, second, third?
Oh, yeah, we have the already organized that. Let me see here. I pass it on to Rafael. And you are going to be the first because you are the keynote speaker. Natarajan is going to be the first, and then Yuzuki Oshima will follow. Maybe it's too late over there, and I guess he's almost finishing surgery. So Oshima will be the second. And we have the list here, and Dr. Lam the third, Nageshwar Rao fourth, Dr. Francine Vega, 5th. Gustavo Hanning, 6. André Jucá, 7. Saad Wahib, 8. Dr. Yonekawa, 9. Dr. Lawrence Chong, 10th. And Emmanuel from Greece, 11. Why have Seti, Marcelo, 12. Why have Seti, 13. Rodrigo Pegado, 14. And Rafael Rantes, 15. And the last. Maybe we are not going to have the video from Rodrigo. It was not ready, but he's going to discuss on some of our cases. And André Jucá, good morning.
Good morning, my friend. How are you doing?
Ça va bien avec toi?
Très bien. Bonjour à tout le monde.
Bonjour.
And Hudson, did you get my video?
Yeah, yes, I got your video. Yeah.
So you'll play my video?
Sure, it'll be a pleasure. It's here as well.
You sit there?
And, you're just waiting for more 5 minutes to start.
Sure. I just want to check whether things are working. That's all. Hi, Lawrence. How are you?
Hey, fine, Dr. Natarajan. How are you doing? Hi, White
Very
Ching.
good.
Good to
Very
see
good.
you.
Nice to see you, Lawrence, after a long time.
It's been a while, yes.
Yes. I was just telling Hudson that it's about 15 years back I came to your house.
I know, it's been a while.
Yes.
You've got to come and visit again after all this virus finishes.
I know.
After all these virus and things, we're going to have a meeting. I already told Dr. Divini that we're going to make a big party in each country, like one in India, one in Canada, one in Brazil, and USA.
Yeah.
We're going to be having, to spend the whole year traveling to other countries. And the thing is that I want to know Bolivia as well, because I found after so many years, I realized I have some relatives in Bolivia as well. And so me and Marcelo Murillo, we became relatives.
Oh.
After such a long time, I realized I have relatives there, because my father is, his name Nakamura, Japanese, but he's got this Bolivian descent as well. So relatives from my father's part from Bolivia as well as in Japan. I might have somebody in Japan because of Nakamura, but I don't know. I probably have to ask Yuzuki to find that out for me. I don't know.
Nakamura. Hi, Yusuke. Hudson, Gustavo has sent a message in WhatsApp that he's not able to log into Zoom.
Oh, yeah. Okay, I will.
I already sent the link to Retinawesome, so he can enter by
Okay.
the link.
Good morning. Good morning. Sorry, good evening, Nageshwar Rao and Vaibhav.
Good evening. Sir.
Good evening.
Good evening.
Hi, Yoshi. Good morning.
Good morning.
Good morning.
So you got an angiogram behind you.
Yes, so some Coats disease action.
Yeah.
Oh. So
Very ugly looking.
I have something to do that with my presentation today.
Oh, nice. Looking forward to it.
I'm going to do the surgical for Coats disease.
Beautiful.
So he had put it as a mystery case. I didn't want to change it.
Oh, sorry. I messed it up for you.
I know. It's all right.
Hi, Joshi.
Hey, how are you?
Everything good.
Hi, Yoshihiro. How are you doing? Everything's fine?
Yes, Hudson, thank you for organizing this once again. It keeps
it's a
getting more and more
pleasure.
extravagant.
What do you have behind you? You have this falciform retinopathy. What is that?
Yep. It's an angiogram in a kid with Coats disease. So you could see the aneurysm and telangiectasia.
Looks great.
Yoshi, many congratulations for a few achievements in the last few weeks. I congratulate you in the Facebook for your.
Oh, yes. It's been fun. It's been a busy couple of weeks.
Yes. Proud of you.
Always for you.
Hudson, What about YouTube? Did you enter?
Yeah, let me see now. Did you get the permission? No, they still don't give me the permission to live stream.
What about Rafael? Does he have in his computer the permission to enter to your account? Or only your computer?
Rafael is his co-host as well.
Again, you can name it co-host.
Yeah, he's already co-host, Rafael.
Okay, but so he can be host to play in YouTube. You can name Rafael host.
Yeah,
Okay.
Rafael, are you around?
Yeah, I'm here.
You are ready. I will give you the host for you, and then you try to connect the meeting into the YouTube. I'll give you the Retinawesome password, okay?
Okay.
So you are the host now, and everybody's dependent on you now, so don't lose your connection.
Okay, just wait a minute.
Lot of pressure.
And Rafael has been there for since the beginning of Retinawesome. Rafael also was organizing the Brazilian Congress of Ophthalmology last week. That was a great work, and I want to give compliments to Vibhav Sethi. Hi, Vibhav. How are you?
All well. Awesome.
Yeah, everything all right?
Brazilian meeting had 6,000 people in your online meeting.
Yeah. We had a synchron and a online meeting because presentations were performed in local in São Paulo, and then some part of it was recorded previously to avoid failure. It was very interesting.
Hi, Gustavo. How are you? Please put a picture.
Gustavo, how are you, my friend?
Now yes, I was muted. How are you guys?
Good, Gustavo. How are you?
Excellent.
You're logged into 2 places.
Yeah, let me see now because I connected both and I will turn this one off. So I have just one connection. Happy to see you all here.
It looks like you're doing a double action.
Awesome.
Let me just change this.
So your new position, you have a bigger beard now. What I saw you in April and now.
Yeah. Actually, it's not as big as I want, but so far so good. I'm enjoying it. I see many good friends here. Vaihap, Dr. Juka, Dr. Awai Chin Lam, our friend Oshima, konbanwa.
Hi, Gustavo.
How are you, Hudson?
I'm fine. How is your weather? Likewise, we are so hot here in the Goiânia.
No, today is a little bit, actually for Brazilian patterns, cold and humid, very humid. And it's starting spring here and I have allergies. So my face, pollen is everywhere. My face is a little bit under edema. It's okay. I don't have conjunctivitis so far, so I'm happy.
Yeah. And you are working okay, or you reduced your schedule?
Actually, I'm happy because since 2 or 3 weeks ago, patients are starting to coming back to the office because before they were afraid of the COVID situation. But it is a pity because I'm seeing some retinal detachments with PVR and all of that because they should have come before. And they were afraid, and we know patients don't have the appropriate education. So let's see how we're going to handle that. Other situation, also patients which were treating AMD, they didn't want to come. So now I have a patient who has been 6 months without injections, and he has a big scar with, I think it would, I'm not going to be able to treat it back. So it's a pity, and we still haven't seen all the consequences of this situation, but let's go ahead. We have to.
Yeah, many patients of mine from choroidal neovascular membranes, I had to forcefully switch them from treat and extend to treat as necessary because they just disappeared, and they are coming back now, but mostly are cool, so it's still good, and we are now grabbing them to continue the treatments.
Yes, yes, that's the big
Rafael,
problem.
if you want to start the meeting, Rafael, and Natarajan is there now, and he's...
Sorry, Hudson, how is the YouTube connection? Everything okay?
I gave all passwords to...
Yeah.
So we are live in YouTube as well?
No. The problem is, Marcelo, probably the account that was created this meeting wasn't Hudson's. So I think that the one that can stream for YouTube should be the one that have created the event. I think it wasn't yours, right, Hudson?
No, it was from, but that's not a problem. That YouTube, we get the stream from cloud, from Zoom, and then we share. It doesn't need actually to be live because everybody has the Zoom password, so that's not a problem. So we could start this, and no problem at all. It's okay for me.
Yes,
and
we are recording also.
I'm explaining here. I was telling people that was telling Dr. Lam that Retinawesome is from us all, and we are broadcasting from Bolivia. It's a pleasure to have Marcelo agree with that in laboratory point, and I thank very much Angie Cepeda from the laboratory point, because that was awesome to have accepted this. And we have this policy here in Brazil that after the Brazilian Congress of Ophthalmology, after a time 15 days before and 15 days later, we cannot broadcast the event from here, but so that's why the event is being broadcasted from Bolivia. But next time it's going to be broadcasted from elsewhere. It doesn't matter. It will be an honor for us to have the event broadcasted from Hong Kong, from India, from Singapore, from everywhere, and from United States and Canada. And because this Retinawesome is a group of friends, and you are all friends, and we are learning, and then we're going to be sharing these videos and discussions. And so if it's broadcasted here and there, for me it's the same thing, because we are all united. Thank you, Rafael. I'll leave it up to you for starting the meeting and then calling Natarajan.
Yes.
Okay. Thank you very much, Hudson.
Rafael, can we put first the video?
Okay. I lost the screen. So who's asking?
Marcelo.
Yeah. Can we broadcast the video?
Yes, it's already playing.
Okay.
Okay.
Okay. I just cannot get the audio.
There's no volume. Marcelo, no volume.
Yes, it's Angie. Can you put volume, please? Okay, if you want, we can start.
Okay. Okay, friends. Hello. Good morning and good afternoon to everyone. It's a great pleasure to start our 5th event together with dear friends. So without wasting time, let's start our event. So Professor Natarajan have our first case, and he's a dear friend from the first Retinawesome. So Professor Natarajan, do you want to start here now?
Hudson, you can play my video.
Sure, I will do that right now.
Good morning to my friends, and good evening to this part of the world. So I think I'm going to present a case on video on a surgical management of Coats disease, and we have Yoshi having a Coats disease angiography in the background. But we have patients who are coming to us very late or probably with a white reflex, and I think many times they don't know what to do. So this is the video where it's a novel technique of external subretinal fluid drainage for exudative retinal detachment secondary to Coats disease.
Whenever you want me to start,
we can start. We can start right now. Yes. So yeah. So this is presenting a case of a 5-year-old girl diagnosed with left eye Coats disease. Her presenting vision of perception of light, and the left showed a total retinal detachment with a subretinal exudates and a macular scar. And she was initially managed with the peripheral cryo and Avastin injection, and you can see the picture like this. And she was managed with peripheral scatter laser and injection Avastin, and during further course of the treatment, still the SRF drainage was SRF was not reducing. So I followed this technique where I use a 27 gauge infusion line. You see case here. I learned the 27 from him. So there's only the 27 gauge infusion, and then after that I actually everything is external, and except I infuse the eye, and then I use the viscous fluid extractor. First, I localize with the forceps using the indirect ophthalmoscope to make sure that the needle is not going in the, it's exactly going in the subretinal space through the transconjunctival, transscleral, and so, and then you make the viscous fluid extractor on, so that simultaneously the infusion will be going and make up the globe, and also give intravitreal measuring and giving the intravitreal. I usually give Lucentis at the conclusion, and then also prior to the peripheral. And you can see post-operatively the exudative retinal detachment observed. This is a diagrammatic thing which we can see the subretinal fluid being drained, and then having the infusion line to keep up the volume of the eye. We have published this in a journal, where the reference will be, I will post the reference shortly in the chat box, and then simultaneously infusing the eye. This is the post-operative picture where the retina is totally flat without any vitrectomy. And then in case still there is an activity, you can give a anti-VEGF, and also do the aim is to have an anatomical success to prevent secondary angle closure glaucoma. This is a modified transscleral external drainage of subretinal fluid in high bullous exudative retinal detachment due to Coats disease, published in 2012 in the Women Journal of Ophthalmology. So the idea is we can make actually the eye looks good, and then the fellow eye can be followed up. And even though you can't get vision, at least the child, when they grow up as an adult, can be as a normal looking eye. Thank you.
Thank you very much, Dr. Natarajan. It was a beautiful case and great illustration. Dr. Oshima, do you want to comment on this case, please? Your mic is off.
Yeah, can you hear me?
Yeah, perfectly.
Okay. Congratulations, Nati. It's very nice technique, I think, because you use a very small gauge and they're a safer technique. So, sometimes we encounter such a very extensive detachment case. We should take care not to do any more internal bricks to aspirate the aspirate fluid. Sometimes we encounter PBRs in just a case. So the external drainage is very nice technique, and the key is how to do it much safer, just like you talk. They're very nice. Thank you.
Thank you. I have seen Dr. Eckhart doing a vitrectomy and then making a retinotomy and making a large retinotomy and then removing all the exudates, PFCL, then oil. And finally, sometimes you will end up some cases in PVR. But sometimes he has got a beautiful anatomical success. But I think finally we want attached retina, but the vision doesn't improve whatever you do because these are all late cases. But I think as you see the background of Yoshi, where he has the angiogram, where you can do a excellent laser in the capillary non-perfusion areas or in the the telangiectatic vessels, and I think those eyes probably will do well when there is no submacular exudation. Gustavo wants to comment.
Sure. What are your tips, Nati? Because we have young people watching us today for when you are dealing with their first exudative case, because they are tricky. Sometimes you get confused and you might create problems. You have already mentioned someone, despite making new holes to promote more PVR.
Yes. So I think the tips to the young people is, this is like a white reflex. So I think they have to keep always in a child retinoblastoma as a differential diagnosis. So if it is a retinoblastoma, the entire approach to the patient will be different. And like a benign conditions like codes can be desired later. But I think when in doubt, definitely nowadays we can exchange the pictures through the seniors, asking for the opinion, even using the email or the WhatsApp, and or take please call the senior colleague when you're in doubt. But I think you should not, I think even in this much experience, and I think sometimes when I have a doubt, I always send the mail and ask questions. And I think I kept in my own hospital group, Hudson, so he keeps answering about patients. Because recently we had a similar patient in a 28-year-old, somebody diagnosed a subretinal hemorrhage as an adult onset retinoblastoma, but looks like a hemorrhage. So I think there can be confusing patients. But coming back to this Coats disease, I think one confirmation is the peripheral telangiectatic vessels, and you see subretinal exudates. Unlike retinoblastoma, will have a creamy thing, which I think when you're in doubt, ask for a CT. Sometimes you are exposing the child, but I think when you're in doubt, better to err towards the side of retinoblastoma. The retinoblastoma you should not enter, and in case you enter, you make sure you start the chemotherapy, because otherwise there will be secondaries and the child can die. So I think you have to be extremely careful in managing a white reflex in a young girl or a young child.
Very good, Nati. Thank you.
Excuse me, sir.
Yes, Nagesh.
Sir, recently I treated a patient of adult onset codes. But the thing is actually it's a bit changing what we see in youngsters actually. But the teens, the course of disease is different. But in adults, particularly, they respond well to this one peripheral laser and anti-VEGF. But particularly in my case, I do not know. But I treated that case only. But it did not respond to anti-VEGF alone. When I injected steroid, that responded well. What about other panelists?
So your point is well taken. When there is no exudative retinal detachment, the laser works and anti-VEGF works, and you don't have to do any intervention surgically. But if there is a bullous RD like this, exudative, then only you have to differentiate and then do the subretinal fluid drainage instead of doing a vitrectomy and producing complications. And anyhow, he wants others to answer.
I can say a few things. I think your surgery was really beautiful. I've never seen such a non-invasive type of procedure for exudative coats. And I agree that the first most important thing is rule out retinoblastoma. Just to add to your many pearls, a few other things that you can consider also is looking at the vasculature in retinoblastoma. The vessels kind of dive into the tumor. In coats, it doesn't. Fluorescein helps to see that. And also, there's a term also called xanthochoria. So retinoblastoma causes a white pupillary reflex. Leukochoria, Coats disease, looks a little yellowish. So that's xanthochoria, and that can help. And we usually talk about boys getting Coats disease, but I have plenty of patients who are female who have Coats, as was your case also. And so examining the other eye, I think, will be very helpful. If you see tumors in the other eye, that's retinoblastoma. And I think the way you used the infusion cannula in the pars plana to infuse the eye, that was really nice. And it was perfect for this eye because there was space, there was surgical space in the pars plana. But if the retinal detachment is even more larger, like the retina up against the lens, then you have to use the AC maintainer usually for the transzonular infusion. But this was the perfect surgery for this case, and it was really nice.
Thank you. I think it's another point. If there's a bullous and it almost sometimes comes up to the lens, and then I think you are better to use the AC maintainer. I think it's important. I mean, some surgical tips where you can prevent complications, and I think that's why you have to anticipate complication, then you will not get a complication. So that's why I never use the word "you're lucky that everything worked well." No, there's no luck. I think everything is pre-planned, and still I think in spite of all the planning, in case you miss somewhere, and that's where the problem starts. Exactly like the accident in the road. It's not just like that, but I think you do everything what is required. And then if it happens, I think, then if at all, you can call it accident.
Dr. Natarajan, very nice
Yes,
case.
Lawrence.
You know, it's interesting that when I used to do these and you do it externally, you feel the fluid and it feels greasy. You know,
Yeah.
I don't know if you've noticed that. It feels very greasy, like it's oil. So
That's right.
I found that very interesting. The other note for young people is that cryo increases inflammation. So I've tended to avoid cryo in these cases, and because of the inflammation. So when I used to do these cases, I would drain flat and then try to avoid cryo, and then to try to laser the lesions if I could. Because cryo can cause such a bullous detachment.
Yes, I think that's a good point. You can drain, leave it with an anti-VEGF, and then when the retina is flat, you can do the laser. Or even on the table with a depression, you can do an indirect laser.
One way to, I agree, laser on attached retina works the best. There's one way to modify the laser so you can treat bullous retina too. So even if it's detached, we have to be very careful about titrating it, but you can use continuous or long duration in kind of painting the vessels so that you make the vessels white. And that tends to work, but I agree, it doesn't work right away. You may need multiple sessions. So ideally the retina's flat, or I think cryo works great, but I agree sometimes it causes more exudation in some patients.
But Yoshi, there is a way to treat these lesions in detached retina. Mm-hmm. And I used to inject ICG and use infrared laser, and you can actually close off lesions in detached retina in that way.
So photodynamic therapy with ICG, I remember.
Yeah, if anybody has infrared laser anymore, you know.
Yes.
I think the blood vessel that's there usually allow you to laser the vessels because it is pigmented. So, and I agree too. The fluid comes out often latent with cholesterol, and you can see even at times chunks of cholesterol crystal being drained, especially if you drain externally with a sclerotomy. So I think the key point has been mentioned by the different speakers already, that in all possibilities to do an external drainage, and there's no need to go into the eye. The bigger the amount of exudations, the more it makes more sense to do the external drainage than the internal. And once it flattens, you can see the amount of subretinal band, and maybe sometimes pre-retinal band. But then you can assess if there's any need to do further intervention at that point.
So I think it's a good lesson for the all young people. I think this is a usual complaint from the previous generation teachers in vitreous surgery, that most of the young surgeons do not know anything to do less. They always want to go in. And I think that's a good lesson, and which probably Hudson and Gustavo asked a question. The residents or young doctors are there in this Zoom now. I think the idea will be to find out the least way to treat an eye. And I think this particular case is an example. I'm happy all of us are agreeing, do the least by doing an external drainage. All of us are aggressive vitreoretinal surgeons. I think in the last 4 retinawesomes, we saw everything which we are doing through the past plana. And I think that's the reason I was thinking I should do something as a keynote speaker. And I'm happy we brought out a point to the young people that everything old is not bad, and everything old is also not great. And I think you should take up, which is good for the patient. And I think that's what I think is a good last point by Wei-Ching Lam. Is great that we as an experienced teacher want to tell the students, please pick up the right thing to do for the right patient. And whatever you hear, don't apply directly without knowing what it is. And I think you should have some experience. And when in doubt, please ask. Just don't do with doubt.
Thank you very much for all the comments. We should go to the next case. Thank you, Dr. Natasha. Dr. Oshima, do you want to share your screen to see your video, please?
All right. So just one comment about the last case and not to talk about. Of course, also very agree with the other doctor talk about the laser mainly for the stabilized aneurysm. But sometimes, you encounter very big hemangioma. It's not easy to use the laser only. So in such case, I still prefer use the cryo. Cryo combined with intravitreal injection, the steroid, you can stabilize the inflammation in most of that case. Otherwise, the big one, I don't think laser is a workout for such a case. All right, let me give a talk about this maybe the traditional strategy for the option for the subretinal hemorrhage treatment. I just show you some option, and I would like to discuss with the panelists about which would the best way you like to do for such a severe case. So, can I see my slides?
Yeah, perfect.
Okay.
Thank you.
So, the natural cause for the subretinal hemorrhage due to the AMD is very severe. So we need to use some surgical or the pharmacological strategy to treat this case. So recently, most doctors recommended use the anti-VEGF, the injection, but just like this case, of course, this case is very, the activate CNV with the wide subretinal hemorrhage. How would you like to treat this case? So some doctors still talk about simply use the anti-VEGF. So anti-VEGF can stabilize the neovascularization activity, but it's not easy to resolve the subretinal hemorrhage so immediately. So anyway, at the end of the day, you can see, of course, you can slide the neovascularization, but when you use the autofluorescent, you can see a very wide layer of the post-pro, the degenerative RPE. So even though you can stabilize the activity and resolve some hemorrhage, finally you can see it's a very big scotoma and the fixation point shift to the near the arcade. That's the reason why you can only get very low visual recovery. So the much more less invasive surgical approach is simply use the gas for the displacement of the subretinal hemorrhage. This is a typical case with the PD and the subretinal hemorrhage and the sub-RP hemorrhage here. So simply inject the C3A with the expansive gas. You can utilize pneumatic displacement. You can displace the subretinal hemorrhage. So this case works very nicely. So you can displace the subretinal hemorrhage to the inferior side and only leave the PD here, so you can get very better visual recovery in the case. But not only every case can be rescued by such case, especially if it's not a fresh case, it's not sometimes doesn't work. For this example, this case, if you use inject, here show you our standard technique for the pneumatic aspiration, pneumatic displacement subretinal hemorrhage. I simply prefer use once this is syringe, first aspirate the aqueous humor 0.3, inject 100% C3 gas 0.5 millimeter into the intraepithelial cavity, and make the face down position for 5 minutes. Then you can accumulate the aqueous humor, refill the volume to the antechamber, so you can re-aspirate the aqueous humor 0.2 millimeter more. So totally, it can balance the total volume with aspiration and injected volume. So in this case, you can see we can work very nicely, and you can get a very excellent visual recovery. There, I show here, not every case can rescue by this simple injection. For example, this case, we are a little old subretinal hemorrhage. Even inject gas, it doesn't work. Another case here, we can encounter the vitreoretinal hemorrhage, a much more severe case, which more dense hemorrhage. And otherwise, vitreoretinal recurrence will occur in such a case. So in such a case, I still prefer use the surgical approach, vitrectomy combined with subretinal injection, TPA, and sometimes also combined with the anti-VEGF drugs. And make the fluid exchange of the volume of the 50% intravitreally, and you just like the accelerate the accelerate the displacement of the C3 of the gas. So here there's a schema scheme we how to use it, and this is the original technique already reported in several previous literature. We use a very small gauge needle to inject the fluid and expand the artificial detachment, and with combined with TPA or end with anti-VEGF, and with wait about 30 minutes, and you can liquefy the subarachnoid hemorrhage, and you can locking technique and shaking, and make it much easier to make sure the BSS with subarachnoid clot. And finally, you did inject only 50% of the vitreous cavity of volume, the gas, and C3, and can make the face down position a couple of days, can displace the subarachnoid hemorrhage. So if the case with hemorrhage only localized around the arcade area, this sometimes the paper talk about this is massive, but we don't see it as massive. It's a moderate subarachnoid hemorrhage. We prefer use the technique to accelerate the displacement of subarachnoid hemorrhage. Here show you the 27 gauge surgical technique. This is a little bit old video. We use the dark cannula. And this is the 29 gauge twin light chandelier from the Bastron right now. It's commercially available. And then use the wide on view system. You can see this is a little bit old subarachnoid hemorrhage, so it's not easy. You only use the gas only, can displace the subarachnoid hemorrhage. So I prefer use the subarachnoid injection. So initially I do the iron peeling, and then I inject the subarachnoid BSS with TPA. And generally the concentration maybe around 50 microgram to 100 microgram per injection. Otherwise, we encounter some subretinal toxicity of TPA. So no more than the 100 micrograms better. So in this case, a little bit old one, so I prefer to create the artificial detachment widely, and then wait for about 30 minutes. And then use the locking technique to shaking to create the attachment much wider and make sure the BSS with the subarachnoid clot. And then try to use the gas, not fulfill the gas in the vitreous cavity, only about 50% or 60%, because leave the other place to can displace the subarachnoid hemorrhage to the inferior side. And simply move all the trocar cannula and to enter surgery. So, as you know, Dr. Tamer also deployed much more fancy technique, the subarachnoid air bubble injection. But the one concern about it, my personal impression about it is that if inject the bubble so quickly, you may separate the adhesion between the retina and the RP. So sometimes, of course, you can display the subarachnoid hemorrhage or subarachnoid clot to other place, but sometimes you're encountering the much higher damage to the photoreceptor. So personal opinion, I prefer still use the BSS to gently separate the retina from the clot and separate it from the RP to avoid much severe damage to the photoreceptor. And shown this case that we can get very good favorable results. How about the much more challenging case? This is the bolus attachment with the wider subarachnoid hemorrhage. Sometimes this case in Asian people, we often encounter this situation because most of the people that AMD is due to the PCV. Once the picture rupture, they may encounter much more severe, just like this show here, the total attachment with subarachnoid hemorrhage. And in the case, we already published the previous paper, the video, about how to treat that one. So most of the surgeons, like the European surgeon, prefer use the large or the wide retinectomy or retinotomy to invert the retina and directly aspirate the subarachnoid clot. But most of the surgeons show such a technique, a very skillful surgeon, so he can do it very well and use the silicone oil to tamponate and stabilize that the subarachnoid CNV activity and attach the retina very well. But wider retinectomy and counting PV are much easier, especially the case, the AMD case, sometimes that RP is already very severely degenerated. It's not easy to attach to the retina. So for us, we innovated a very small, much what's it called, less invasive technique, because in such a case, it's not we recommend not make the retinal breaks at the posterior side, because such a case, the RP around the posterior side already degenerated. So once create some intergeral hole to aspirate subretinal hemorrhage, after that it's not easy to attach the retina, close the posterior breaks, because that the RPs are degenerated. It's not easy to attach the retina. If once you encounter, you make the posterior hole, you may encounter PBR much easier. So even such a case, peripheral RP is most healthy. So we prefer, in such a case, we try to perform the intravitreal injection TPA 1 or 2 days before the surgery, from surgery. And of course, during the surgery, we also prefer to inject the TPA, just like the last case showed. But in this case, we inject much more widely to make a much wider lesion attachment. Because we have the experience with the translocation, we don't care about how wide or how steep bolus detachment we can create. And the point is to create a peripheral retinectomy at the upper side. You can do the temporal upper side or nasal upper side. You can make 2 or 3 breaks there, because we can try to, in the case, we try to use the tip powerful carbon to displace the subretinal hemorrhage from the posterior to the periphery, and makes the evacuation of subretinal hemorrhage from the peripheral retinal breaks. And of course, in such a case, you cannot remove the subretinal hemorrhage 100% during the surgery. You should encounter some subretinal hemorrhage still remain underneath the retina, but don't care about it, because in such a case, we finally repeated this technique, injected the perfluorocarbon, aspirate the hemorrhage, and then shaking, and then inject more and aspirate it. Finally, you can still reduce the volume underneath the retina, but you cannot remove all the subhemorrhage, of course. So finally here, we don't like to use the silicone oil. We simply use the cryo to make the retinopexy and inject the long-acting gas in it. And then we make the face down position after surgery, and then we can use just like the pneumatic technique to displace the subretinal hemorrhage from the peripheral retinal breaks we made. Because we use the cryo here, it's not laser. So even the subretinal hemorrhage passing through the retinal breaks, the long-acting adhesion by the cryo can finally seal the retinal breaks in this technique. So in just a technique only used to make the small breaks at the peripheral area. That means much easier to attach the retina and count much less in the case of the PBR. We already used this technique for over 20 to 25 cases. We have never encountered any PBR in such case. The one drawback is we need to remove the lens, because when they accelerate the subretinal, remove the crystal lens. If the pseudophakic eye is okay, because even the pseudophakic eye that displays subretinal hemorrhage into the antechamber, you can aspirate from the antechamber by the paracentesis a couple of days after surgery. So here showed how to treat the case. This is a case with wide bolus detachment with subretinal hemorrhage. And here is a 27 gauge. And you can see here, and the very dark clot. And initially we perform the peripheral shaving. Of course, we create the PVD. And then use this 27 gauge and 41 gauge subretinal injection needle. They will use the active injection to inject the PPA with BSS in the subretinal space. And you can see the increasing the volume of the subretinal space here, show here. And waiting about 20 to 30 minutes, you can liquefy the clot. Just like show here, the color changes to the much fresher red. And then we use the shaking technique to make much wider area of detachment. And here make the clear to break the breaks from at peripheral area, and then gently inject the TP, the powerful carbon. You can see the very dense and the sand-like the high viscosity subretinal hemorrhage can passing through the peripheral area. So with the technique, you need to repeat it several times, but finally you can get to remove the around maybe about 70 or 80% of subretinal hemorrhage. Only remain a little bit, still accumulate at posterior, but don't care about it. After the end of surgery, make the pneumatic displacement can demonstrate that the residual subretinal hemorrhages passing through the peripheral bricks after the face down position. And the DM surgery can see easy to close out the wound. And here show this case. Finally get, this also show here, we can get the complete subretinal hemorrhage removal without encountering any severe complication. Folks, in such a case, it's the most RP already damaged, so the visual defect already maybe occurred, and the visual recovery may be very severe, but you can prevent the blind, even such a severe case. So my personal choice of the surgical option for the subretinal hemorrhage treating is, if it's not massive hemorrhage, if the fresh case, we use the pneumatic displacement. If the dark clot case, we can use PVD combined with the pneumatic displacement. If a really old case, of course, it's very challenging. If it's a last eye, I still try to use the surgical approach. But it's if it's a failed eye, it's a visual acuity, it's worked very well. I just simply use the VEGF and the VEGF to stabilize the neovascular activity. And if it's very bolus subretinal hemorrhage case, severe case, if it's a fresh one, I try to use the PV vitrectomy with the TP injection subretinally. And if it's a dark clot also, just like this case, I showed you the surgical approach. And with the old case, the old one, I just only do the observation, because if it's a much more severe solid clot, it's not easy to liquefy. It doesn't work even with the subtechnique. Otherwise, another choice is a wide retinectomy to remove all the subretinal clot, but that may increasing that complete high incidence of completion about the PVR. All right, thank you for your attention.
Great, Yusuke. I think wonderful surgical techniques. And the only comment is that the last case where you did you injected a TPA, waited for 30 minutes for blood to liquefy. Once I operated Mark Humayun's aunt, who came from Pakistan, and then it was about 25 years back. So bullous subretinal, and that time I was not confident of doing the TPA and then doing it. So he told me, why not you do a vitrectomy? 25 gauge that time, 27 was not there. It was, I think, 2005. So we did a 25 gauge vitrectomy, inject TPA, and put a C3F8 and put her on head-up position. All the subretinal hemorrhage came down from the macula at least, and then the inferior hemorrhage went away. So I think the patient got good vision, and then later did a PDT. So maybe that one option is there for a massive subretinal hemorrhage for a surgeon who's not very confident. But a surgeon like you and me, we can do this TPA and clear the entire thing and have a good visual results.
Yeah.
Thank you very much.
Yeah, other technique they can use the external drainage of the subhemorrhage, but just we'll talk the subject. External drainage cannot remove the 100% of the hemorrhage during the surgery. So this technique, the one advantage of this technique, you can use the pneumatic displacement to displace subretinal hemorrhage from the peripheral retinal bricks.
Thank you very much. We have short time here. I'll ask Dr. Lam to comment on this one too, and he can present his next case. Please, Dr. Lam.
Thank you. Oshima, that was beautifully done for such a large subretinal hemorrhage. I totally agree with you that among Asian, PCV is a quite common problem, and when they bleed, they tend to have a large bleed and making it difficult to manage. And I think the internal drainage gives you the advantage of having to more complete, as you mentioned, drainage of the subretinal fluid. And I like your technique of just cryoing the retinotomy and not lasering it, considering there might be some fluid and some difficulty managing them. So I think that is a beautiful technique that you have shared. And I think the smaller amount of hemorrhages, I found pneumatic displacements is quite adequate and does not require intravitreal TPA as some literature suggests. And
that's right. Yeah. In small cases, simple gas injection can displace the stubborn hemorrhage very effectively.
Yeah. So I guess I would start sharing my screen.
Yeah.
And share. Okay, so my case is a somewhat complicated anterior and posterior pathology. So it's a 2-year-old boy with bilateral Peters anomaly with concurrent FEVR and microphthalmia. So if you're on trouble, this is trouble staring at you. And unfortunately, his left eye didn't do so well, despite multiple surgeries as listed on the slides, that he had graft done, a lensectomy, and unfortunately developed progressive tractional detachment. Vitrectomy was done, oil, but eventually you can see on the B scan, there was a total detachment, and you can see on the external photo a essentially physical eye that's developed. And the right eye has a similar kind of process, needed a couple of penetrating keratoplasty, lensectomy was done, and there was starting to develop some peripheral corneal decompensations. And here is the change that you can see in the anterior segment, as well as the anterior part of the retina, where there is a progressive anterior tractions, where the anterior retina was dragged forward temporally, and there was also a pupillary membrane developed posterior to the graft. So one of the approach that I decided to do was to do the endoscopic assisted ciliary body dissection to remove all the adherent membrane that drag both the anterior retina and the bridging the membrane covering the ciliary body. That did buy us some time, but unfortunately 2 months later, he has additional problem. As you can see on the slides, that there are progressive tractional band that developed in the posterior pole and posterior to the equator, resulting in tractional detachment and multiple localized tractional detachment that involved extramacular as well as the macular. So because of those anterior displaced retina, so the decision was to put in the anterior chamber maintainer to do the procedure. But those people who have used anterior chamber maintainer, you know that after a while, the cornea will get edematous. And you can see the view to the back is somewhat poor because of the corneal changes. And secondly, using a single hand to try to dissect the membrane there was difficult. And I couldn't put a chandelier because of the anterior tractional displacement of the retina. So I get a light pipe to help. And realized the cornea is getting progressively worse. So I get one of the cornea colleagues happened to be in the building. It's advantage to be working in a large hospital, a children's hospital in Toronto. And he come in and helped out to open up the space that we need to. So he did a removal of the cornea, and then I now has the access to do a open sky by manual dissections of the tractional membrane that is both in the anterior part of the retina as well as the peripheral part of the retina. And And I found that to dissect posterior to the crater is somewhat difficult with the microscope light, but with the biome and with the endoilluminations, you can have a very good view to the posterior segment. Combining with visco dissections, putting on heat on help to keep the space of the posterior segment, and you can see just now that it provided more opportunity to further dissections. Because the case was unplanned for a PKP, so the same cornea was replanned back to the eye and allowed that to clear on its own. So open sky vitrectomy is a very old technique, but in this particular situation, it was just the right thing to do, at least for myself. On a very extreme small eye with a lot of the anterior pathology and meeting the requirements of bimanual dissection for the adhering tractional membrane for a single instrument dissection is impossible. Of course, when you do open sky vitrectomy, you need to worry about the complications associated with the hypotony, the risk of suprachoroidal hemorrhages, and the expulsions that can come with that happened. The key for this particular case was try to reattach the posterior pole, so that is only trying to address all the posterior tractional membrane. And the anterior dissections was quite limited, but they were not important in this particular situations here. So I'll stop sharing, and so we'll open up for the discussions, and it will be interesting to see how the other panelists would manage this case if they have different approaches.
Thank you very much, Dr. Lam. Very challenging case, as always. So I'll ask Dr. Yonakawa. I know that you do pediatrics either, so do you want to comment on this?
Yes.
He's a perfect person to comment.
Yeah.
No, congratulations on the beautiful case. It was like watching Tatsuo Hirose operate. And so Dr. Hirose, for those of you who don't know, he's one of the fathers of pediatric retina surgery, and he's now retired only recently. He was practicing until very recently, but he was at Harvard, and he was the king of open sky vitrectomy. And he would dissect stage 5 membranes from throughout the world. And a lot of his cases did really, really well. And I would see his post-op patients in my practice when I was practicing in Boston who were 20, 30, 40 years old, and they look great. And some didn't, but a lot did. And he uses a similar technique with the flingering. And one thing I think that he also does, he maintains a cool infusion, kind of just drip, drip, drip into the pupil. And the cool water helps vasoconstrict to minimize bleeding also. But it's a very challenging technique. I loved what you did looking at through the biome, because I don't think that was ever really done, open sky vitrectomy with indirect viewing to the posterior pole. So that was really elegant. And so that was a fantastic learning for me also. Regarding Peter's anomaly, these cases are so tough, and they are very, very challenging, especially so I think that from a cornea standpoint, you try to avoid transplanting as much as possible, but they progress also, and you just have to sometimes, and the PKs often or almost always fail within a few months or a few years. And so I feel like a lot of these kids in our practice end up with pediatric capros, keratoprosthesis. And there you can maintain a good view to the posterior pole, a good visual access, but the capros cause lots of problems also. They tend to melt, get infections, and we have a few kids who have done well, and but many don't. And one paradigm that we were thinking of together with our pediatric cornea colleagues is doing a capro while the visual cortex is developing, to give that to develop the visual cortex to prevent amblyopia, especially of course in bilateral cases, and then switching to a regular PK which will be safer in the long run, but the visual cortex would have developed, and then do another repeat transplant when they're older. And so we haven't really gone into implementing this yet, but that was an idea that we were thinking of. But super, super tough cases, beautiful surgery. I learned so much from your case.
Thank you. You're very generous in your comments. And I found it very interesting what you just mentioned about using the K-Pro in children. So I don't have much experience. I guess our pediatric cornea specialists have not done much of the pediatric K-Pro. And it may be a challenge to switch from K-Pro to graphic because the way that the K-Pro kind of suture into place, and it takes up a fair large of the corneal and the scleral junctions there. So, but very good suggestions, and that could potentially provide a longer, sustained, improved outcome for this particular group of patients. I totally agree. Whenever I get a call from my cornea colleagues, I know I'm in trouble because that's usually because they have a Peters that they want to co-manage. So
I agree. It's never good when pediatric cornea calls you.
Yes. Very good.
Thank you very much.
Tatsuhiro say. I think he was a great surgeon. He has visited India many times, and he has operated several babies from both Chennai and probably many parts of India, and those days when we were not doing ROP. And I think he was always swearing upon an open sky vitrectomy. And he has trained two of the surgeons here, and my mentor, Dr. Badinath, was his co-trainee with the students in 70s.
Thank you very much for the comments. Dr. Chong, do you want to comment on this case?
You know, the few times that I've done open sky for ROP was a long time ago. But I agree with you, Wai-Ching. It's like the best way to visualize and attack the peripheral trough with bimanual and scissors. It's amazing the view that you get.
Thank you very much. We should proceed to the next case. Dr. Rao, do you want to share your screen and start your presentation, please?
Yes.
Thank you.
How to this one save this?
Yeah, you have to go to the share screen button on the bottom of the Zoom.
Dr. Rao Nagesh, if you want, I can share it to you. You sent me the video.
Yes, but the thing is actually, I wanted to control my video while I was speaking.
Okay, that's fine.
So,
okay.
Who can share? It's when I clicked, it has come. Who can share? Only host or all panelists? Who can start sharing when someone else is sharing? Only host or all panelists? What to do?
No, I think you're having some trouble. Do you want to pass to the next one and then come back, or do you want Hudson to share your screen? Your video, actually.
I can share it. It's easy for me here. Okay. It's already on the spot.
Okay, so do it, please, Hudson.
Okay.
Okay.
This is a case of this is a case of 52-year-old male who came with sudden loss of painless loss of vision.
If you want me to stop the video, you just tell me I stop.
Yes,
okay?
yes. Stop the video here. Stop the video here. This is a case. Just can you go a little earlier to my presentation? Start up my presentation. No. I wanted to start. It is moving. Hello.
You want to stop it here?
No, little earlier, the beginning. Yeah. Please stop here. This is a case of 52-year-old male, sudden loss of vision in left eye. This is in fact what Dr. Yusuke has actually described submacular hemorrhage, massive submacular hemorrhage, subretinal hemorrhage. He has described very well with TP injections and all, but this is a very simple case of massive subretinal hemorrhage, which he came, 50-year-old male with sudden loss of vision in left eye of 1 week duration. Then examination, we found vitreous hemorrhage, dense, the vitreous was filled with dense vitreous hemorrhage, and ultrasound examination, just can you go, please? Ultrasound examination revealed this is the vitreous was filled with dot echoes, that is vitreous hemorrhage, and a membrane echo, which is retinal detachment, but underneath, please, underneath the membrane. So this is the vitreous hemorrhage, which clearing. But one thing what I would like to say, tell is, particularly this vitreous hemorrhage, particularly suppose it is PCV, this one. In PCV cases, particularly the vitreous hemorrhage which remains is a smoky vitreous hemorrhage, and PVD induction becomes very difficult. I found, and one should be very careful in actually inducing PVD, because the retina remains very friable, because it is stressed, the blood which remains under the retina, which makes the retina very friable. So you will make lot of retinal tears while inducing the PVD. One should be very much careful in inducing PVD. Well, suppose if you are not getting the PVD, one should not try attempting the PVD. In that case, actually making so many retinal breaks is a possibility of making so many retinal breaks. Then what I did is just I finished the vitrectomy and did a fluid exchange, and because lucky that the patient was having not subfoveal hemorrhage, the hemorrhage was limited to periphery only, and injected C3F8. After 4-5 months, the patient just came with cataract. The fundus was very good, and we operated the cataract, and the macula was looking so nice. He got good vision. This is probably the scar, which is usually the PCV scars, which leaves this type of scars. Finally, the patient got 20/40 vision. Thank you. Thank you very much.
Great case. And you've got so dense hemorrhage. And
yes.
How long did it take to do the vitrectomy, the whole vitrectomy up to the periphery?
Pardon?
How long did it take to clean up the vitreous entirely?
Entirely, I took nearly 30 minutes.
The vitreous was very dense.
Very dense. Was very dense.
Get away with that.
Yes. Suppose in that cases, actually, what I felt is because it makes very difficult to separate the vitreous. So that is the reason putting a band is always wise, because sometimes you may create retinal tears. At least the 360-degree encircles may take care of that. And I learned actually with my practice, I learned this, because earlier also I did a few cases that landed in repeated vitreous hemorrhage, recurrent vitreous hemorrhage, and the retina got with PVR changes, what Dr. Yusuke was telling. And it's so in that case, it's actually gentle vitrectomy and removal of the some post attachment of the vitreous carefully, and avoiding the retinal tears is wise in dealing with these cases. Thank you very much.
Thank you, Dr. Rao. Beautiful case. Dr. Cirino, do you want to comment on this one? Francini?
I'm sorry, I was opening my mic. Good morning, everybody, and good afternoon to you all. Very good case. I think this is very elegant technique. He used the scleral band with a silicone band passed through the sclera that I like it very much. And it was very elegant how did you were able to drain the choroid. So I think that was very nice case. Thank you for sharing.
Okay, thank you very much. Now we should proceed to our next case. That is yours, Dr. Francini. Do you want to share a screen, or do you want for us to share it?
No, that's okay. I can share it.
Okay.
I was thinking about which case to share with you today, because there's a lot of beautiful cases here. So I decided to share a case that it's not so common. And as at the last reunion, we shared the hashtag technique, I decided to share this one with you today. It was a man, 81 years old, that he had suffered a blunt trauma with a high pressure machine, and he presented a lens dislocation and was referred to surgery. At his first surgery, he had the intracapsular fascectomy, and then an anterior vitrectomy because he had no holes and no fragility at the retina that was seen in that moment. And it was performed the netback technique that gained this nickname as hashtag technique and Leo implantation. And this was the end of the surgery. He was very okay. He was very fine, very stable at the moment and at the follow-up. But 30 days after the surgery, he was assaulted and was under aggression. And he had this striking on his left side, this left side of his head, and he got this big hole and a retinal detachment. So we thought, and now, how we were going to perform retinal detachment surgery with this netback hashtag technique, and the lens is going to be stable or not. I really didn't know how to approach it. But then, as the visualization was so nice, I decided to do the surgery as it was. So he has, we did this 42 band, silicone band under the scleral lamination that I like it very much because they're not sutured. We identified all the proliferation that he had, the PVR, and we manipulated under the retina because he had a little bit of hemorrhage over there under the retina. And then after we removed all the PVR and all the contraction, we did the fluid exchange, and then we did the laser all over the retina, and we took care to do the retinectomy to maintain the retina very flat. And then we did the fluid exchange and silicone oil exchange. And at the end of the surgery, the lens was a little bit dislocated, as you see here. Then we stop and think, no, so what are you going to do now? Do I take this lens off? Do I take the hashtag off? And I left without anything, and I just put silicone oil. The silicone oil is going to be touching the cornea, and probably I will have to do some cornea transplantation after. But as the surgery was very nice, and I thought the Leo could be stable, so I decided to maintain the Leo, maintain the IOL, and then I captured the optical zone under the hashtag and finished the silicone oil exchange. This was the aspect of the final aspect of the surgery. And after this, this was my consideration at the time, to put gas, to put silicone oil, but then I prefer to put gas because we had that big retinal tear, big hole, and others holes in the retina. And this was the final result. He has the hashtag technique here. The IOL is under the hashtag, and he had 20/60 after the silicone oil removal after 4 months, and the cornea was okay. So this was the case that I would like to share with you. Thank you.
Thank you very much, Dr. Cirino. Dr. Sasamoto, would you like to make a comment? Okay, so probably he has a problem with connection. Dr. Mavrikakis, Emmanuel, do you want to comment on this one?
I don't know if anybody in this room has intimacy with hashtag technique, it's not so difficult to do, and it's an option. We should think that we should not perform it in young people, because somebody says that the prolane is suture that can have influence of the sun, and it can degrade it by the time. So some people say that you should use Gore-Tex. It's another suture that it's more grosso. Woodson, help me.
Thick.
More
Thick.
thick, more.
It's thicker.
Sorry, I don't know if Gustavo Honey is in the room. He has a little. He also described the hashtag technique. This technique was published the first time as net bed technique. It's from Brazil. It's Novelli Teodomiro, and they had a lot of cases without any complication. And it's very stable. It's very nice, but sometimes we have this kind of surprise here.
Very good.
Yeah.
Yes.
Just want to comment. Yeah, I learned about the hashtag technique last time in the Retinawesome from Francine, and that was the first time I heard it. And since then, I actually looked it up, and I've seen your beautiful work. I think that was wonderfully done. And at the beginning, I didn't think that the hashtag is sufficient to hold an IOL. I know that people have used that to keep silicone oil from migrating to the front in the aphakic eye, and that seems to have worked very well. But you have shown that the hashtag technique is a very safe way to even support a sulcus placed intraocular lens implant. So I now actually include that in something that I might want to do in situations when I run into similar to your case. Particularly, I think in a aphakic patient where you have silicone oil, I think it is a fantastic way to keep the silicone oil from getting into the anterior chamber. Thank you.
Yeah, it's true. Thank you for your kind comments.
Is it also called the lasso technique? There's a thing like lasso technique. Is it the same as hashtag technique, or is it different?
Sorry, Dr.
The last technique is different. Is another technique.
Okay.
This one, first of all, Francine, congratulations. Amazing, beautiful technique. You did it very elegantly. Who also presented this was Dr. Samuel Masket from California, and it was presented as the safety basket technique. He had a subluxated IOL, and he used it. Tip, which I like this technique very much, because in the public system is one of the only resources we have sometimes for secondary IOL implantation. If you use Prolene 9 zeros, it will last much longer, because the 10 zeros is, like you said, is too thin and it might break with the time. I had some with 10 zeros. So far, the patients are good, but they have 5-6 years of follow-up. I'm waiting for the 10-year follow-up to see if something happens or not. I'm gonna let you know when we have Retinawesome 100. Congrats.
Thank you. Thank you very much.
Excellent, Francine.
Thank you. Now, we should proceed to our next case, which is from Gustavo Henning. So, Gustavo, would you like to share with us your case, please?
Sure, it's a pleasure. Hudson has my video. Can you share it, please, Hudson? Hudson.
Yeah, sure. I'm gonna share it right now.
While Hudson prepares the screen, this is a little bit different thing I'm gonna present. It's a posterior case for anterior surgeons, because I know they are watching us here very silently, but it's a good thing. Sometimes when you don't have, you are lacking of resources or looking for other things. Yes, you can play it, Hudson. Okay. So this is a luxated lens. You're gonna see now when the video starts. I enter with a 5 millimeters knife, 5.2 actually. And I enter with the infusion and I elevate the pressure trying to bring this nucleus out. First, I do an anterior vitrectomy to free any vitreous which could be promote any traction in the periphery. Here the infusion escapes, but with a slight touch, I bring it out, okay? And now I'm gonna do a vitrectomy again because I'm not sure if vitreous came. Usually it comes a lot. I have some small piece which is left in there. So again, I bring it really, really gently out. And since it's already open and the only 3 pieces IOL I have in the public system are from PMMA 5.2, I use it to make a Yamane technique, which works with our friend Washima, who is here with us today. I do the flange, and I like to do one another then other. Here I'm gonna do a handshake technique. I enter through the paracentesis. It makes easier the procedure. I dock it in a 25 gauge needle. I don't have 27 there, which would make it easier, or thin wall needles. I center it, and then what we have to do, it's not a secret for anyone. I have it centered. I suture the incision. I could have done 2 stitches, but I feel safer in 5 millimeters incisions to make it 3 stitches. I bury the knots. Don't ever forget to do it. It's really important, or you're gonna have symptoms, infection risks. And after that, we take off the infusion and we make it easier, sparing this patient's eye from a more intensive or more aggressive procedure. That's it. Thank you.
Thank you very much. Very beautiful case. Dr. Honey, you made it look simple and easy, but we know that it isn't like that. So I would like to ask Dr. Vihab to comment on this one, please.
Yes, Dr. Huning, very nicely done, and I like the way you just push the lip and the nucleus just pop out of there like a delivery, and so it's a very interesting way of just pushing in the infusion and bringing out the nucleus. But I mean, the good part was you did a good anterior vitrectomy, and you made sure that there was not much of vitreous prolapse out there. So great case, and I like the way you use the handshake through the side paracentesis and the Yamane technique. Very cool. Thank you.
Thank you. Very important. Before raising the infusion, first do the anterior vitrectomy to don't have the nucleus bringing all that vitreous out. So you do it, and when you're gonna touch the limbus to open the incision, then you raise the infusion and it will come out. Thanks, Vihab.
Thank you.
Oh, thank you. Before asking Dr. Sasamoto to comment on this one, I would like to ask you, Gustavo, which lens did you use? Because we know that in Brazil we don't have CT Lucia, and it's something from Brazil that we are curious to know.
Sure, Rafael. Thank you for your question. To make life easier and save our time, I'm gonna write now in the chat so everyone can know which IOL I was using, okay?
Okay, thank you. Dr. Sasamoto, do you want to comment on this case, please?
Yes, in these cases, I prefer to do a transscleral fixation. I feel more comfortable with that technique. I believe with Yamanes in the future, because of the thinning of the tissue, you're going to have some problem. I really prefer to do some scleral patch to protect to put more security to my lens. So I usually do that, but it was an excellent video, and congratulations, my friend.
Thank you.
Thank you very much. So does anyone want to make a comment on this? Hudson?
I don't personally perform the Yamane technique, but the thing that when you raise the intraocular pressure and the lens just flows, and then you get some vitreous back and doing the anterior vitrectomy, your technique is so good. And I attempted to do some, but with an anterior segment colleague. But the thing is that the lens, the intraocular lens gets a little tilt, maybe because it's the lens we use. and maybe we would have to have another appropriate lens, intraocular lens, for a better case. But in your hands, with more experience, the lens was just perfectly fit into the eye. Congratulations, very good.
When I grow up, I want to have your technique, Hudson. Thank you.
Yeah.
Thank you.
Thank you.
Thank you very much, guys. So we should proceed to the next case. Dr. Juca, would you like to share your screen, please, and present your case? Your mic's mute. Okay.
Hi, everybody. I just brought a case here from a large macular hole from more than 1,000 microns. And in these cases, we think that we have to change a little bit our technique.
We don't see your screen, Dr. Juca.
Okay, I'm going to try it again.
Please.
Okay. Let's see. Now it's working. Are you seeing the screen? Okay.
Yeah, now it's good. Thank you.
So we think in big macular holes, in macular holes that has more than 650 microns. Our standard technique does not has the same level of success. So in this case, we try to change the technique to improve our success rate. And we here in this case did this technique that was presented first by Carl Meyer to failed macular hole surgery. We are doing this in this first case of because the macular hole was big and an old macular hole. So we are using here the brilliant blue to remove the internal limitant membrane. But we do not like very much the flap technique, IOM flap technique, and we are using here to try to give more tissue to close the hole. The injection of fluid and supraretinal space. This is a small tip that we cut this Med1 41 gauge cannula to facilitate the insertion over the retina. It's make easier. Then we do like 3 or 4 bottles. It's very important to separate the border of the hole from this adhesion that he has, and then we perform a fluid air exchange with this technique that was first presented by Carsten Meyer in 2007. We think that we can increase the rate of success of this larger hole without big trauma or without impeding the migration of the cells, the photoreceptors to close the hole. So we are trying this only on, of course, in big holes that we think that the rate of closure is smaller than in our regular cases. Well, that's it. And we have also another case to comment. Maybe you want to comment this one, and the other one is it's also a tricky case. You want to comment on this one, and then may I present the next one, or this? Rafael.
Okay, I think we should open for comments on this one. Dr. Mavrikakis, do you want to comment, please?
Sure, a great case, fantastic. Yeah, sure, the large macular holes is indeed a problem, and I think that definitely you need to relax the tension, the tangential tension around the hole so it closes. So I find it quite beneficial either to massage the edges or perform the subretinal fluid injection. So you release space and tissue for the hole to close. Yeah, excellent case. Thank you so much for sharing.
Okay, Dr. Ruka, do you wanna? Oh, so sorry, Dr. Lam, do you wanna comment on this?
Yeah, just that I totally agree what has been presented with Andre, and there was a publication from the group in University of Toronto. I think there was about 12 cases managed in this way that Andre has shown to create the detachment, and for this exact reason that he described, to free the edges so that the hole can close. I think this technique is far better than stuffing stuff inside the hole, whether it will be IOM membranes or the autologous retinal tissues, because I think there's nothing better than your own tissue that fills into the gap that is there. And any extraneous material, amniotic membrane, IOM, or even autologous retina are just not as good a replacement tissue as having the edges of the hole sliding in. And I think this is something to consider for the very large hole, not necessarily needed for the smaller under 400 micron hole. Beautifully done.
Okay, another case that I would like, another situation that we are facing more often is with floaters and in patients with multifocal intraocular lens in particular. We have done some floatrectomy, and most of them are not cases of the ones like this, that's asteroid dialysis. And this patient was really bothered by this asteroid dialysis, and we try to guess why some patients are bothered, because most of them are not. Indeed, we did a review of the literature, and we find that only about 7% of the cases of floatrectomy are done in patients with hyalosis asteroids. There is some tricks to do vitrectomy in patients with intraocular multifocal lens and floaters. First of all, we try not to perform a PVD. We just try to remove the opacities as much as we can. And we try to perform a 27 gauge surgery with 10,000 cuts that we think is perfect for this situation. This patient is like 20/20 J1 visual acuity of near and far, very good. So this is really very tricky because we cannot perform any mistakes, any holes, and do not have any, of course, ruptures. So these cases, you see this kind of lens are very often, and this, why these patients are so bothered with this situation. We think it's an issue of contrast sensitivity that's already low in this, with this kind of intraocular lens. And we think also that this situation leads to lower contrast sensitivity, because these floaters, they disperse the light, and then the patient has loss of contrast sensitivity. Maybe a way of measuring that also is trying to measure the high order aberrations. That's it's much increased in these cases also. Most of the patients do not have hyalosis, asteroid hyalosis. Most of the patients just have thick floaters. And it seems that when the floaters, they are close to the macula, or in the other hand, they are close to the intraocular lens, is that the one that bothers most of the patients. The situation is a little bit tricky because there is some neurotic patients that do not have a lot of floaters, and we have to try to distinguish these two populations of patients. But we think that we are seeing this more and more in our clinic, and I would like to share this with you. Thank you.
Thank you. Thank you, Dr. Hilka. Thank you very much for this beautiful presentation. Dr. Chong, do you want to comment on this in particular?
Yeah, you know, my partner Jerry Sabag has looked into it, and I agree with you, Andre. He has actually done contrast sensitivity before and after floater surgery, and indeed he has shown that contrast sensitivity is lower and it improves after the vitrectomy. So I think you're right. I think the floater decreases contrast sensitivity. Asteroid hyalosis decreases it further, and then a multifocal intraocular lens decreases it even further. So I think you know, the contrast sensitivity is the correct key to this.
Yeah. So thank you very much, Andre, for beautiful two cases. Dr. Yonekawa, do you want to share your screen? And if you like, you can comment on any of these cases, please.
Okay, sure. So great case with a floaterectomy. I tend not to enjoy doing too much, but those end up being the happiest patients. And asteroid, I think, is very interesting because without a PVD, these patients are very asymptomatic despite all the glistening stuff that we see in their eyes. But I feel that when they develop a PVD, which tends to be, might be more delayed, I guess, because the gel tends to be very sticky in these eyes also, that they're very symptomatic. But very interesting topic for sure. So I'd like to share a pediatric case, and I think a lot of us are thinking along similar lines. Can you see the title page here? Okay.
Yeah,
And,
yeah, that is
okay,
good.
perfect. And we were thinking about Coates disease today. We were thinking about endoscopic surgery today. And this is a very unusual case of a funny looking eye. And so you can see that the eyeball itself is normal size, but the cornea is microcornea, about 5 millimeters. And it's a very rare syndrome called MPPC, described by Mike Tracy. And these patients have microcornea. The lens is very big and posteriorized. It's called posterior megalolenticonus. These eyes have persistent fetal vasculature, as you can see here, and a coloboma. And this patient also had a tractional retinal detachment. And these cases tend to be bilateral, but unilateral cases have been presented. This patient is unilateral, so I told the parents that, you know, just observation is reasonable, but they requested do something about it, you know, give the eye a chance. So I said, all right. And here, let's get started. So it was a very tough case from a visualization standpoint. And you can see how small the cornea is. And we take a limbal approach here. And because we have no real view to the pars plana, it's so anterior. And the retina was drawn up anteriorly, so I didn't want to go into the pars plana, which may not even exist in these eyes, and hit the retina. So we make limbal incisions, and we're using a 25 gauge short infusion. And this is used for ROP cases, and so it has a shorter infusion. And we were taking the lens out first, which is very, very kind of rubbery and gummy. And so the lens is abnormal, the capsule is abnormal too. And here we're extending the limbal incisions over here so that we can insert a endoscope. This is the 19 gauge one, which I prefer to use over the 23 gauge. I think the view is just a lot better. And we're using the endoscope here because despite using biome, the pediatric biome, contact AVI lens, there is just no view because of the optics. We could barely see with the indirect ophthalmoscope. The RetCam somehow got a very nice view, but surgically it was very challenging. And so we had to kind of take down the microscope and use the endoscope instead. And so here you can see the remaining capsule and the traction that's kind of all over the eye. And we're using MaxScript forceps here to remove the capsule, very adherent to the ciliary processes, which is very kind of abnormally developed as well. And you can see that the endoscope gives you a very nice view of the strands of the vitreous. I think visualizing the vitreous is really beautiful when you use the endoscope. And so what we're doing here is going around the PFV stock so that we can release all the traction and allowing it to settle and doing air fluid exchange to prevent vitreous incarceration. So that's the video, and he did really well. Do stop share here, and the on follow-up ultrasounds, because the view is always challenging. The TRD gradually it became more settled, and so I thought that was an interesting case of a rare condition and an interesting use of the endoscope as really the only means for visualizing in the eye. I'll be happy to hear what you think.
Thank you very much, Yoshi. A very challenging and beautiful case. Congratulations for doing this kind of surgery. I would like to bring Dr. Len to comment on this one. Please, Dr. Len, do you have experience on that?
No, I think that case is beautifully done by Yoshiro, and I'm just thinking, I think pediatric VR cases is always challenging, and if they have the added so-called anatomical anomalies, it makes it even more difficult. I think there's a great use of the endoscope for the surgery, and I think you're absolutely right, you're absolutely right that with the endoscope, the vitreous actually are much easier to see than the standard endoilluminations of the vitreous, and I think I cannot imagine this case by doing any other way than what you have shown. So I think it was really, really well done. I just wondering the whole eye itself is whether it's just microcornea or there's other kind of anomalies that's developing, because to have that thick lens and the abnormal posterior capsule, I think itself is, as you describe it, maybe as Mike Tracy is correct, that it is a syndromic constellations of abnormalities. So, but
yeah,
well done.
I'm not sure if this is published yet, but one of our friends has done whole exome sequencing, and so there seems to be a genetic component. And so just in case that's not published yet, I think that'll be interesting to be on the lookout for. This particular patient also had other abnormalities behind the eye, and I forgot to mention, but on the title slide, there was an ultrasound showing orbital cysts. And so something definitely went wrong developmentally.
Does the patient also have a coloboma?
Yes.
Yeah. So we've been seeing the cases, and we have published optic nerve coloboma associated with retroorbital cyst. And we have quite a number of cases that we have seen among our group, the patient with optic nerve coloboma. And there is a even suggestions that the retroorbital cyst may be communicating to the coloboma that may be responsible for some of the retinal detachment that we see. So the detachment you see actually may be exudative rather than people propose as a rheumatogenious, where there might be a break in the center of the coloboma that causes that. And we have shown a couple cases that you can treat them with thiamine oxide medication that kind of help to reduce the cysts that could actually end up resulting in the retinal detachment settling down. And our former fellow, C.K. Patel in Oxford, also has published a couple case report showing the presence of retroorbital cysts and medically treating those detachment associated with optic nerve coloboma. So interesting case that your case has the same kind of manifestations that we were interested in.
Thank you.
Yeah. Thank you very much. So now we should proceed to our next presentation, please. Dr. Chong, do you want to share your screen? And if you like to comment on this one, you're free.
Let's see. I don't really have any comments. I learned a lot from both Dr. Lam and Dr. Yonakawa on the last case. Let's see.
I think just click on the green button, so it will expand, and the left superior.
Oh, okay. This one
in your video. Yeah.
Great. There we go. Well, this is a parapapillary choroidal neovascular membrane, and we don't do this type of surgery for the macula anymore. But I wanted to show this case. This is the way. Here we've done the vitrectomy. We've injected. We're injecting fluid underneath the macula, and then I've taken out the 25 gauge cannula to enlarge with the sclerotomy to allow for some submacular forceps. And then we reach underneath with a flexible nitinol tip to separate the choroidal neovascular membrane from the photoreceptors. And here I'm reaching underneath the retina to remove this membrane. And what I wanted to show was how big this membrane really is, even though it hasn't affected the fovea yet. And we would never do this case underneath the fovea because we would remove all the photoreceptors. But I thought this case was timely for this meeting because it's about timeliness of intervention. And you could see if you wait too long how big this net would be. And as we know, from gas, that basically these eyes don't become symptomatic till these nets are really huge. And so I think the moral to this story is that even though you can watch these for a long, long time, by the time they get big, by the time they affect vision, they're really, really huge. And I think that although we would probably treat these with anti-VEGF, I think that this is still an option for patients who may live far away, who may be lost to follow-up from anti-VEGF. And I think this is a reasonable approach if it's not underneath the fovea. But that's my film.
Thank you very much. Very beautiful. Dr. Sasamoto, would you like to comment on this one? Your mic is off.
Okay. I wanted to ask you your protocol in this type of patients, with the anti-VEGF.
Yeah, probably my first choice would be anti-VEGF, and then surveillance, possibly every 3 months, something like that, and to treat it and to treat if there's any sign of fluid.
Thank you, Lawrence.
Sure.
Thank you, Dr. Juca. Would you like to comment on this one?
Yeah, I'd like to ask, a very nice case, Chong. Did you think it's useful to use anti-VEGF in the pre-op of these cases?
I think that I think it's very useful to prevent bleeding. And then the other thing the other thing to prevent bleeding is when you remove the net, just raise the intraocular pressure when you remove that net.
Okay, thank you. Dr. Lam, would you like to comment on this case?
Yeah, no, Lawrence, I think I missed this type of surgery when the submacular surgery study come out, because this is before the anti-VEGF era where submacular surgery was done to remove the membrane. And soon we realized that removing the membrane from the macula wasn't that helpful, especially for the type 1 membrane. And the type 2 membrane, meaning that if they are above the RPE, they come out nicely. And particularly, I think, and I think we have a small series too of peripapillary membrane that did very well. And those membranes tend to be quite large, and they run the risk of hemorrhages and exudation that migrate towards the macula. And if I have a patient with the peripapillary membrane, I think the surgical approach makes so much more sense. And you show it so elegantly that we all have that kind of feeling, like seeing the baby being delivered through the retinotomy, having the membrane taken out. And the RPE underneath the macula is preserved because they were not involved in there. So I personally still think this is a good technique. For those people who haven't done the submacular surgery, despite the very large kind of retinotomy that was made with the 20 gauge submacular surgery instrument, those retinotomy never need to be laser. They just close. As long as you've done a good posterior PVD and not creating any residual like bleeding in that area, and then it's fine. Raising the infusion bottle is always what we do when we take out the membrane, because they might have some attachment to the underlying choroidal vasculature that cause bleeding. But beautifully done. I missed those surgery.
Yeah, and you know, it's pretty definitive too, because the recurrence rate is low. It's pretty interesting.
Yeah, I think peripapillary membrane, that's the way to go, personally.
Sean, which forces did you use to remove the membrane?
It's a submacular forceps that you can purchase, commercially available.
Yeah.
But it's not. It's 20 gauge. It's a 20 gauge forceps.
Yeah, it wouldn't matter. The retinotomy closed, so it's not a concern at all.
Yeah, the difference is that the submacular forceps, the ends of it are very long, so you can reach through the retinotomy to have the membrane.
Okay, thank you very much. Thank you for the comments. Now, Dr. Mavrikakis, would you like to share your screen and present your case, please?
Can you see my screen?
Yeah.
Great. First of all, let me thank Hudson for the kind invitation. Very honored to be among such an esteemed panel. It looked like, you know, in July, August, I was chased by intraocular foreign bodies. So this is a 65-year-old gentleman who presents into the ER with reduced vision in the right eye after hammering metal. So the CT scan shows intraocular foreign body in his right eye, and
sorry, we cannot see the image. It's just small, you know. We just can see the Windows Explorer.
Can you see it now?
Yeah, the ultrasound.
Yes. Did you see the CT scan, or shall I go back?
No, we didn't see it.
Okay, so this is the B scan showing no retinal detachment and an inferior located foreign body that appears to be on the surface of the retina. And let me go back and show the CT scan. So, and this is the CT scan. You see this? So this is the intraocular foreign body in the right eye. And let me now share with you the video. So the gentleman had a perforating corneal laceration that was primarily repaired by the ophthalmologist at the time of the presentation in the hospital, and then the patient was hospitalized and referred to me for secondary treatment. So what I have to manage is the repair. You see my video now?
No, we can see. We are in the CT scan still.
Oh, why is that? You see now?
No, it's still with the CT scan. I think it would be better if you stop sharing and then share your video.
Okay, thank you. Anything now?
Just the Windows Explorer page. I think, Hudson, do you have the video?
No, he doesn't.
No, he didn't.
Okay.
But you could click on the video and then.
Okay, let me do that. So,
no, if I may suggest,
do you see the video now?
No.
Stop sharing your screen, then open the Windows Media Player, which I think you are using, and then put share screen again, then choose the Windows, because the Windows Media Player doesn't go well with the Zoom platform. First, open the video. It's a tricky situation.
Okay. Let me first open the video then. Sorry about this.
No problem. If you open the video first, it's going to be there. You just then share the screen.
Okay.
Great suggestion. I didn't know that, Hani.
Yeah, that's a problem with Windows Media Player. I learned on the worst way, believe me.
Me too.
So, have I stopped sharing now? Yes.
Yeah.
Okay. So I open the video. Great. Okay. And now let me
share the screen that the video is on.
Then you're going to see a small window of the video.
Give me a minute. Because I need to minimize it. Exit this. And go to Zoom. Share screen. But there is no video here.
Another thing is that you can send me the video via WeTransfer, and then I downloaded it here, and then we proceed with presentations, and then you present the last case. I will share your video, no problem.
Okay, sorry about that.
Or open with other application than Windows Media Player. Try to open with other application.
Here we go. Give me a minute. Do you see it now?
Yeah,
yes.
Yeah, that is okay.
Thank you.
Perfect.
Okay, great. So I have the case that the cornea has been sutured by the eye surgeon in the OR, in the emergency room, and now I have a traumatic cataract. And I imagine that the foreign body has gone through the anterior capsule, through the lens, through the posterior capsule in the retina. So my whole thinking is to preserve as much of the capsule and remove the foreign body, and then have a place to place an intraocular lens. Let's find out what's happening. So I inject a bubble in the anterior segment. I dye with vision blue, and then, as you can see, yes, the foreign body has gone through the capsule and it has created this star and the impact. So I go in with my capsulorhexis needle and I try to incorporate my anterior capsulotomy within the place, the impact site, which I manage and I create a curvilinear capsular axis. And then as I complete my rexis, I do a very gentle hydrodissection because I'm sure that the posterior capsule is compromised. So I very gently mobilize the lens, and then with very low phaco settings, I try to remove the lens very gentle without creating a posterior capsule rupture, and then the lens will drop at the back. I managed to remove the lens with, as I said, very low power settings, and then as you can see, indeed the lens is removed, and this is the rupture of the capsule from the foreign body. I do an anterior vitrectomy just to push back as much vitreous as I can, because I want to remove the soft lens matter with a bimanual IA technique. Otherwise, I won't be able to see clearly with the soft lens matter. And I manage this. As you see, the capsule is clear. So I have anterior capsular axis, the posterior capsule, and then because I inject Kenalog and I create a PVD because the patient did not have a posterior vitreous detachment. I do a complete vitrectomy and I thoroughly save the vitreous, especially inferiorly. There is no break. The foreign body has just touched the retina, and I just do prophylactic 360 laser on the impact site, and then I try to remove it. As always, the first time, it's always difficult. The foreign body snaps back and falls back, and then I try to reach it and catch it more steadily, and then I have this great idea. I have this posterior capsule opening. So what I do, I just ask the assistant to remove the biome, and then through the posterior capsule opening, I direct the foreign body, which is quite large, through there, and then very gently place it on the iris. I then inject some viscoelastic to secure the anterior segment to prevent any falling back of the foreign body. I open my corneal wound, and then with the forceps, I very gently remove it. Of course, as we all know, the direction of the foreign body is not the right one, so it's not coming out. So I reposition it. And then I take it from its longitudinal way, and finally it's coming out. And do 360 sets, there is no breaks, and then I decide, as I have an intact anterior capsule, to insert my 3-piece intraocular lens, and that's the final outcome. Thank you so much.
Thank you very much. Very, very beautiful case. So, Dr. Rao, would you like to comment on this case?
Yeah, nice video it was. Wonderful video. But I could have actually, in between I lost my connection. This was the magnetic foreign body?
Yes, it was a metal magnetic foreign body. That's right.
I prefer to apply the rare earth magnet into the vitreous cavity. It would have actually, I caught the foreign body with the magnet,
And in the mid-vitreous or the entry-vitreous, what you showed, actually, directly I could have removed through the corneal wound by taking with the any forceps, McPherson forceps and all. That would have been better.
Absolutely. The only thing is that unfortunately in my hospital, all my magnets are 20 gauge. So I would have to open my 23G trocar. And because I didn't want to do this, I preferred to cut it with the forceps and remove it through the posterior capsule. But absolutely right, a very great comment. It could be removed by intraocular magnet.
Thank you. Dr. Sethi, would you like to comment on this case? Okay, so
let's the mentor comment about the case. Wei Ching, what do you think?
Yes, I actually messaged on the chat room that you've done a beautiful job, and it's very clever to use the posterior capsular opening to bring the intraocular foreign body into the anterior chamber, and then using your anterior wound to take it out. So you don't have to enlarge the posterior wound. And you're right, if you have used the rare earth method, you will have to enlarge your sclerotomy wound. So I think you've done a very elegant surgery, and the patient loves you, because I think you spare him the larger sclerotomy, and that was just a very, very clever way to handle this intraocular forward.
I think the key to this success was the very gentle handling of removing the lens, because you can remove the lens anyway, but just taking your time and remove it as gentle as possible, I managed to preserve the capsule, and that was the key to success.
Yes, and this can be done because you are a good phaco surgeon. And a lot of the North American retina surgeons are not good phaco surgeons. So we probably will mess up this carex removal if we will try to do it. So I think that's the beauty of your European background training that allow you to do a very good phaco surgery, and thinking of all the risks that you may run into and taking steps to avoid them. Beautifully done.
Thank you.
Thank you very much, Dr. Lam. Gustavo, would you like to comment on this one?
Yes, just a short comment to add what Dr. Lam had already said. Doing a phaco with a previously posterior capsule rupture is not that easy, and Emmanuel managed it perfectly. Very, very good. Amazing case.
Yeah, beautiful case. Thank you very much for sharing this. So we might go to our next case, which is from Dr. Sasamoto. Would you like to present your case, please, Dr. Marcelo?
Okay, perfect. I'll share my screen. Can you see the video?
Yeah.
Okay. So this is a case, a trauma case. There's a place in La Paz, Bolivia, called the Death Road, El Camino de la Muerte. So you are in 4,000 meters above sea level with a bike, and you start to descending to 100 meters above sea level in 15 minutes. So it's a very risky bike performance, but we usually, the tourists do that. And I have, I had one patient that was doing the biking that road and present an ocular contusion trauma in the right eye with a flaxon corneal laceration. So at 24 hours after that, the patient present round-shaped lesions and corneal thinning. 12 hours after it was worse, really worse with popium. So we performed anterior OCT, and we found a corneal perforation. And obviously, before that, we start to the intravitreal injections of voriconazole. We presume it was Candida, and as you know, it took like 48 hours to 3 days to confirm the results. So we have no time. This aggressive fungus was affecting the eye. So we took the patient to the OR and start to do a vitrectomy. What we could see in the fundus, we performed a peripheral vitrectomy and a central also. We were using this voriconazole in the saline solution. Usually use triamcinolone to recognize some vitreous density in these cases with the Candida problem. And it's what doing okay. This is a lyophilized graft of amniotic membrane. We thought that it was going to be enough to avoid this micro perforation problem, and it did. But later, some days later, actually 20 days later, this amniotic membrane started to thin, and we had this ocular hypertension problem. So what we did is take the patient in the OR again, use a corneal graft, cover that perforation, and then put an AMET valve at the moment. After that, the IOP start to go normal, 12, 14. The microperforation was sealed. So it was everything doing fine. The eye start to stabilize, but then the patient start to do exercise. Despite our recommendations, and we got a retinal detachment. And well, we are, I got to the addition of the part of the retinal detachment. In the future, I will show you that it went well, but as you know, it's a tricky problem using these temporary keratoprosthesis for surgery. But in the future, I will show you our results. But that's about it. Thank you very much.
Thank you very much, Dr. Sasamoto. Very beautiful case and complex. Dr. Natarajan, would you like to comment on this case?
I think really, extraordinary case and beautiful skills. I think well done.
Thank you, Natalia.
Thank you. Dr. Cirino, would you like to comment on this case?
Yeah, I would like to say that it was a wonderful case, very difficult, especially because of the fungus and ophthalmitis that you have to deal with. And well, I don't know. I would like to say, to ask if you have any experience with iodopovidone intravitreous.
Yes, I have no experience. I read the article, but I have actually no experience with that.
Yeah, I've already did it, and with a very difficult endophthalmitis recurrence, and it's very nice. It works very well. The problem is that you have to prepare the solution with BSS, and you have 30 minutes to perform the vitrectomy and use the solution. But it's an option. It's not just a tip as an option, and that's it. That was Wonderful.
And the results are very good.
How do you prepare that povidone?
I just put here, sorry, I thought it was for everybody. I sent it to Hudson. I'll send you here one of the articles. They say how to prepare it. You have to, there's a concentration, special concentration that you have, I don't remember actually now, but you have to put it on, diluted into the BSS, and it's stable for 30 minutes. So you have to prepare your everything and start your vitrectomy, and then you use the solution with the iodopovidone under the BSS to perform the surgery. And the results are very nice. It's a good option.
Very good, I think.
Difficult case.
Yeah.
Thank you.
Thank you.
Thank you very much, Dr. Sasamoto. It is very interesting case because it brings us out of our comfortable zone and adds infection as a new and difficult factor. So we must follow to our next case, which is from Dr. Sethi. Okay, can you share your screen, Dr. Wahab? Thank you.
Can you see my screen?
Yeah, that is perfect.
Thank you once again, Retinawesome. It's been a very lovely meeting and so many learning points and pearls from everyone. I'll be presenting a different way of putting the IOL, that is the claw technique. So this case, I'll be showing an elderly male who actually had dislocated IOL as well as a capsule. So here, after making 3 ports as well as making a sclerocorneal tunnel, I'm doing a thorough anterior vitrectomy to clear off the port area as well as to clear off the anterior hyaloid. Now, the key is to clear off the vitreous, do a nice, if there was a PVD already present, but do a proper PVD induction if not there, and clear the vitreous adhesions as well as the vitreous all across around the IOL as well, so that the IOL is free from all adhesions. And then after that, just take an ILM forceps on anything you're comfortable with, even an active suction. Just pick it up and bring it to the front of the eye, and then with your left hand or your whichever hand you prefer, open up the sclerocorneal tunnel. And after opening up the tunnel, you can insert the forceps to just hold on to the IOL. And after that, you just bring it in front. And you can even just place it there for the time being. Then from the side port, you can also go and just scoop up the IOL with the help of a dialer or a spatula and bring it up in the anterior chamber, and then clear it off from the tunnel. This was a part of the how to manage the dislocated IOL. And then comes the interesting part of what to be done. So basically, after examining the periphery and seeing everything is all right, put in pilocarpine. And this is the retropupillary fixated iris claw IOL, which we very often use here. So after checking the patency of the claw, I just put in pilocarpine, place the IOL in the anterior chamber, and after centering it properly, I use the IOL holding forceps and just gently tuck one of the iris claw wings beneath the iris like this and stabilize the lens. So with the other hand, you can use a Sinski just to tap on the iris, but make sure that you basically created a small dimple or a cleft, basically, which indicates that you have actually fixed the iris claw. And in the same way, on the other side, you make sure you feel it. So you push the iris claw in front, you push so that you make a mound of the iris, and then with the help of the Sinski, you kind of just press it down, and with that, you just create a cleft or basically a dimple. So this is how the patient looks post-operatively, and so he's doing pretty well with the well-centered lens, and we use this pretty often in our case scenario. Thank you very much, and I'm open to discussion.
Thank you very much. Very, very beautiful case, Dr. Sethi. So, Hudson, would you like to comment on this case?
Yeah, I loved your case, and the way you picked up the intraocular lens and move it to the anterior chamber. I usually like using these serrated forceps for the lens, for intraocular lenses. And I do the same technique, except that I created this stand-up technique. I do vitrectomy, and then I put a very small amount of perfluorocarbon liquid just to lift up the intraocular lens. And when the lens is this position lifted up, I get the forceps and I grab in the lens, in the ocular lens, in the body, and then I just move it up and I rotate to the anterior chamber. So, and then I go back to the vitrectomy and remove the excessive perfluorocarbon liquid. And in this way, I don't need to use lots of PFO, just a little bit, but I have to remove the vitreous thoroughly. And then the lens just, you know, we grab it very easy. Very good technique, congratulations. And I liked the way you centered with the new intraocular lens.
Thank you so much.
Thank you. Dr. Chong, would you like to comment on this case, please?
You know, like Dr. Lam said, we don't do much cataracts in North America, so I have no experience, but what a beautiful case.
Thank you.
Okay, so our final presentation will be Hudson's case. So would you like to share your screen, Hudson, please?
Yeah, I have a case here. Let me do that trick that Gustavo was showing us. Let me open the video first. Saad asked to apologize him. He had this problem with the connection, but we're going to be displaying his case afterwards in the internet. Can you see my screen?
Yeah, that is perfect. So
okay.
Just put on full screen. Yeah, thank you.
So this was the decisions from this surgery because I ordered the vitrectomy for this patient, and this patient had this very small pupil, but also some cataract, but the lens was pretty clear to go ahead and do the vitrectomy. So the decisions were made whether to remove the lens, whether to operate in a very undilated pupil, and so how we could get good visualization from the eye fundus. And so we have here the macular hole, partial thickness macular hole. And we, regardless of the size of the pupil, we got a very, very good view, 4K from the eye fundus. We are here grabbing the hyaloid, doing effluid exchange. And then we used brilliant blue. See how small is the pupil? This is very interesting because he had some posterior synechia and cataract as well, but with the good lens and with good visualization and good zooming into the retina with the macular lens, we were able to perform the surgery. And so we have here the forceps with a very good staining from the brilliant blue. Another decision was where should I go first? So I decided to go and ahead and do the double peel. So I went first toward the optic nerve. And from the optic nerve, I removed the epiretinal membrane. So I'm still removing the epiretinal membrane all over. We have great staining. Now I'm carrying on with internal limiting membrane. So this forceps is very fancy from Catalyst. Hanning told me about Catalyst. I started using the Catalyst as well. And so see how small is the pupil? And then we are still grabbing the rest of the internal limiting membrane. And it comes out easily because the forceps actually is very good. It grabs, you see, the whitish appearance from the macula now, and we went ahead with the air fluid exchange. And the case is over. So it was, as I was telling, the decisions whether to go ahead and do vitrectomy in that case, many people would probably rather do, let me do combined, let me do the cataract surgery, phaco emulsification, and go ahead and do vitrectomy. And the patient still has the lens clear, has some cataract, but we're gonna operate him the cataract surgery in the due time. And the hole is closed. And we did the double peel, and that was, I mentioned the pinhole effect. You have a very small pupil, you have a hazy media, but still your light comes inside the eye with the zooming and the good macular lens, and we could get away with that without any problem.
Okay,
Excuse me.
thank you.
Excuse me.
Okay.
Hudson?
Yeah.
What was the actually preoperative picture of macula? It was partial thickness or associated with some cystic changes and all were there?
No, the patient had this macular hole, but not very much cystic changes. As I showed in the OCT, he was cool. And the hole was not so big, but then because it was somehow long-standing, but what we call here the PAM, the potential for macular and visual acuity was pretty good. So we decided to go ahead and do the double peel. So we would close easier the hole, and then we did the right way. We could remove both ERM and ILM.
Okay. Ideally, we observe these cases or you go ahead with surgery. That's what actually, because mostly we observe unless until it is actually full thickness. Partial thickness holes we usually will observe.
Well, I don't usually observe, even though it could be partial thickness, but the potential to get better is good. So I go on and operate. You know, my cutoff for macular holes and even epiretinal membranes today is 2050, maybe less. In the past, I used to wait until the patient got 2100, but it's too much. And then the patient could develop cystic changes and chronic changes, and then it wouldn't work as well. So my cutoff is 2050, 2040 minus some letters.
Okay, thank you very much. Dr. Natarajan, would you like to comment on this case?
Yeah, I think what Dr. Nagesh is asking about is, I think the patients sometimes keep demanding what will be the vision. So I think that's the reason he was asking about observing. And if the patients are asking too many questions, I tell them to observe, come back a month later for examination. Because in spite of technically good, sometimes the vision may not improve. But I think in your hands, that's a real good case. And you said the vision is improving to 20/50. It's great. And I think finally the vision is, I think that's what every patient wants. And as a surgeon also, we want to give. I think what you demonstrated is good, but I think the surgeon also has to understand the pros and cons, and the patient too, like the risk of retinal detachment. Maybe 1 out of 100 may develop a retinal problem, and that's why the periphery, we do everything, but still, you don't know which patient will get into vision going down, and then the patient keeps questioning. I think that's why Nagesh was asking about observing. I think when the patient asks too many questions, I think we tell them to observe. I don't think we have to rush through. Maybe you can wait for a month and operate, so the patient understands the pros and cons of the surgery.
Yeah, of course. And eventually the patient is going to get the vision a little worse because of the cataract. But then with the appropriate and technique and the biometry, and he's going to have these operated. And I think that's the way it worked. Okay, that was decision, you know, whether you should do everything going straight ahead, and then you think whether it's going to work. The trick here is to see whatever you see. I always remember Dr. Lam is going to remember this. He always say, you do laser, you have to see, and then you do laser. Whatever you see, you do. If you don't see, you don't do. Remember, Dr. Lam, your advice? So we have to think before acting.
Yes.
Dr. Lam, would you like to comment this either? Sorry, Dr. Natarajan. would you
Sure.
like to complement? And then Dr. Lim can comment.
I agree. I think I agree with Hudson, and I'm sure Wei Ching will say. And I think everything you have to think, and that's why the surgical self-education by Steve Charles in the last chapter, I always tell the fellow should read first. And I think the first thing is to know what is your own experience and what's the everything in the theater, the patient, everything is ready, then only operate. And I don't think my father being an ophthalmologist also told me nothing in ophthalmology should be blind. No blind procedure and no blind approach. I think everything should be well aware. You have a self-awareness as a surgeon, and the patient also is aware of what you're going to do and what you're going to get, then do the surgery. Good, yes, Wei Ching.
And then no blind patients either.
Yes, that's
Very
right.
good.
Yeah, ophthalmology and no blind patient. Correct.
Yeah, but no, totally. I think the basic principle has been already voiced that you got to see what you're doing so that you can do it properly. I think that the use of biome makes life much better for the retinal surgeons because even with a small pupil, you get actually quite a reasonable view. I think Dr. Chang will agree with me that in the old days when we used the lenses, the contact lenses for the vitrectomy, when we're still doing the 20 gauge vitrectomy, when you have a small pupil, it could be a real struggle to try to visualize to complete the surgery. So I think we are the benefit for the improved technology and equipment. So Hassan, you've done very well. So thank you for remembering the small things. You're welcome.
Thank you. I still remember when I started my fellowship back a few years ago in Toronto, I was sitting with Dr. Diveni, and we were using at the beginning these lander systems with rotating the prism lens for the periphery. But Dr. Diveni was already using the wide-angle Volk system, and I said, I use that in Brazil. Let's use it more and more. And after my fellowship some years ago, I see everybody using the wide-angle vitrectomy viewing systems. And so this is something that came to stay. And even for macular work, macular surgery with a wide-angle macular lens, you see the whole thing. So I think that's a good way to go. And Dr. Lawrence, do you use the biome or the contact systems?
Believe it or not, I still use the contact panoramic system. And just a word of advice, it turns out that if you want to do macular work using wide angle, the lens that gives you the best depth of field is going to be the 68 diopter AVI lens. And believe it or not, the 68 diopter AVI lens can only be purchased through AVI, even though it's made by Volk. And the reason is that AVI has the license for the 68 diopter lens. So whenever you order a macular lens from Volk, you can't get the 68. You get their super macula, which I find difficult to use because the 68 is much better. So if you want to peel wide angle, go ahead with 68. My other point is that as I've gotten older, I've become lazier and I like to make my surgeries a lot more simple now. So now when I do macular holes, I don't really peel the ILM anymore. What I do is with a wide field, I just take the finesse loop. And what I do is I peel a broad ILM, temporal to the fovea, and then I peel it like a pages of a book. And I just flap the temporal ILM over the fovea, and then I'm done. And then I do a gas fluid exchange. And if I have failure, I can always go back, and you can always find the ILM with brilliant blue, even months after you do this procedure, and reposition the ILM or do an inverted flap. So now I've become lazy and I don't even peel ILM with forceps anymore.
So Hudson, to your question, I want to tell a story. Like I introduced the biome in 90. I read about Spitzner's inventing in 87. And somehow even in Germany, they were not using it. It's something like when you find something in your own country, somebody doesn't use it. And I think that time the Moller-Weidel had the biome attached to it. That's the reason I went from Zeiss to Moller-Weidel in 1990. And I remember Dijuan visited me and said, oh, no, biome, we can't use and all. But I think nobody accepted it for the first almost 4 or 5 years. And I think in 96, when the Vitreous Society, that's now the ASRS, they did a live surgery from Johns Hopkins in 96, and it was in Rome. And I think they transmitted the live surgery, and he was using biome. And I think it took a lot of time to adapt for the people. And as you rightly said, we are all holding contact lens. And I think my mentor was doing from morning 8 to night 1. And as an assistant, your back breaks. Many times you learn to sleep in the microscope assisting. So I think with those days, I think as Lawrence said, I think AVI lens are really good. And I think if you know the imaging wise, the contact wide angle is the best. But I think I like to use the non-contact because I'm trained in it. And I think what the mind does not know, the eyes do not see. And I think that holds good for any surgeon, maybe orthopedic or a thing. But I think for a vitreoretinal surgeon, I think what the mind does not know, including the anatomy, the pathology behind it, and plus even the visualization. And now using the 3D system, finally you have to be the master of technology, including visualization. And then I think that's what I think finally it's a lesson to the young person. It's not that just you have AVI lens, still you can have complication because if you don't know what you're doing. So I think the lesson is you have the excellent visualization, you have excellent knowledge behind that, and then gain experience in the wet lab, maybe simulator or in the using the pig's eye, and then get to the base. This is advice to the young surgeons.
Yeah, great comments. Great comments. Thanks. And, you know, I don't use the biome, but even though years ago with Marcos Avila and friends from here, Marcel Hemi, and we used the, we did a paper work on the wide-angle vitrectomy viewing systems. And these wide-angle vitrectomy viewing systems, we tested all systems, including ABOS. And the good thing from that is that you know that biome is non-contact. But in our paper, we tested the biome contact. So we arranged the lens in between the patient's cornea in the biome system, and then we tried to approach and contacted it. But it did not work well. The image was blurred, but you know, we don't have the contact system, but that was in the work. The only, in the work in the paper, the only paper in the world that tested biome as a contact fashion. This is interesting.
Good.
And also the other participant from this paper was Arnaldo Cialdini, our friend as well.
Okay. I know IBOS is also good, but I think finally, I think there's a contact, and Avi and Stanley Chang introduced the contact wide angle, and then the work picked up something. And Avi has got tailor-made lenses for macula, as Lawrence said, and I think that's for really precise, for not only surgery, even recording. And I think that's the greatness of Avi's lenses.
So, okay, I think we can close our meeting here. I would like to thank all the participants, especially those ones that have different time from Brazil and from South America. I know that it might be difficult for you guys to stay these hours with us, but all the cases were excellent and very challenging. We learn a lot every meeting, and just thank you. If you want to comment something, Hudson.
Yeah, thank you very much. And Saad, he got the internet connection somewhere because he was having this problem. He said he's going to show his case, and then we're going to put on the Retinawesome channel soon so that you could watch his case as well. But I'm very happy to have here everybody, and especially Dr. Lawrence Chong, that you are a very special person for us, a reference for me especially. And it's an honor to have you here, and for the first time. And great case of yours as well. And we learned with you and with everybody else. And it's good to have Dr. Natarajan as a partner. So we are trying to teach our residents and fellows with our vitretinal program as well. And many things that I learned from Dr. Lam, I still go on and perform. And it's an honor for me to have my professor, Dr. Lam, here. It's really an honor, as we had Dr. Diveni as well some months ago. Thank you very much.
Actually, as Hudson said, every Tuesday, our department and Hudson's department are doing a teaching course, and anybody is welcome to watch. It's Tuesday, India time, 3:30. Brazil is 8 a.m., right? Brazil is 8 a.m. Hudson?
Now?
No.
Yeah, it's usually Tuesdays. Our time is 7 a.m. here, 7 a.m. It's at 3:30 p.m. in India. So 7 p.m. in Japan. And I usually share the links with the times. And this has been a very great experience for me. You know, it's also an honor. I'm learning with you. You know, last lectures were just cool. You should participate, Francine.
I'll try.
Yeah,
It's
welcome.
7:30 a.m., isn't it?
7 a.m. for you.
Yeah, the problem, it's during the week, right?
Yeah, it's Tuesday, every Tuesday.
It's my Hospital das Clínicas surgery day, actually, at the hospital. So it's a little bit difficult, but I really would like to try. Thank you.
Okay, one day, not every day, every Tuesday, maybe one Tuesday.
Yeah, just turn the zoom in then while you are operating. So we get to see you operating. This is a good idea too.
Okay.
Hudson, we also need to thanks to Point Laboratories from Bolivia, Mega Labs, who we are using their platform to this Retinawesome 5. So thank you, Point Labs.
Yeah, thank you very much, Point Lab, that it was made possible for us to do the presentations. And the laboratory Point was so good with us since the beginning, because we knew that we could not broadcast the event from here, from Brazil. And so it was broadcasted from Bolivia, very nicely broadcasted in the arrangements and the arts and the videos and the teasers. I thank you very much, Dr. Marcelo Murilo, my friend, and for you to be intervening with that. Thank you very much indeed.
Thank you, my friend. Thank you.
You think it's late night for him, till 11:30 in the night.
I hope that in the near future we can meet in person.
Yeah. Hope so. We just had a Asia Pacific meeting, and they're doubtful whether the 2021 meeting will be happening. So it's really sad to go through those things. I don't know what's going to happen. Yeah. Hope for the best.
Yeah.
Thank you all.
Hope for the best.
Okay.
Good night, Yusuke.
Good night.
So much.